everybody. Welcome to the session today. I am Dr. Poonam Agrawal, and today I'll be teaching you some other topic in carbohydrate metabolism. And the first metabolic pathway which I'll be discussing will be the galactose metabolism. So, all of you just say quick hello so that we start the session. All right. Right. So, what I'm going to teach you first of all is the galactose metabolism. So the story of galactose begins with the lactose. Just so that we start this. Yes. So galactose metabolism, when we are talking, please understand it's a liver cell where this metabolism takes place. And all this galactose, actually its journey begins with the lactose, which we consume in our diet. That is dairy products, the milk, the cheese, ice cream, all these items, they contain a lot of lactoses. So we consume that lactose in our diet, and this lactose goes to GIT lumen. Now in the GIT lumen, we have one enzyme which is known as lactase, which acts on this lactose to cleave it into glucose and galactose. These monosaccharides, they are absorbed and via circulation they go to various organs. Glucose is utilized in many cells, but galactose is utilized only in the liver cell, the metabolism of which I'll be talking to you shortly. So, till the time the lactase enzyme is adequate in amount and this is going to break the lactose into glucose and galactose, there is no problem as such. But when you talk about Asian population, the deficiency of lactase is very, very common. The most of the newborn child, they have deficient lactase. That results in no digestion of lactose, and that lactose starts accumulating in the GIT lumen because lactose is not digested in deficiency of lactase. So this deficiency of lactase, when seen at the time of birth, is known as lactose intolerance. Where the person is not able to digest lactose and that results in flatulence, bloating sensation, diarrhea, abdominal cramps. These all manifestations are due to making of carbon dioxide and methane gases, which is produced from lactoses. The lactose, which is not digested in the GIT lumen, becomes the treat for the GIT bacteria, which start converting lactose to various gases, the carbon dioxide and methane gases, and these gases are going to give flatulence, bloating, diarrhea, abdominal cramps, etc. So soon after consuming dairy product, the person starts having these kind of problems, and slowly he or she develops the reluctance to milk and milk containing products. This condition is called lactose intolerance, which is very, very frequent question to you. It is just like sucrose intolerance, where sucrase enzyme is deficient, which I discussed to you in the previous session. So lactose intolerance is very, very common. Sucrose intolerance is not that common. But more or less the symptom and signs are going to be same in lactose intolerance and sucrose intolerance. I hope the matter is clear to you now. Now suppose everything is all right and lactase enzyme is acting adequately. The glucose and galactose which is produced in the GIT lumen is getting absorbed in the blood, and via blood circulation it is getting metabolized in various organs. In this session I will be talking to you how this galactose metabolism is taking place in the liver. And mind it, the liver is the only cell where the galactose metabolism takes place. Previous session, we were talking about the fructose metabolism, which is taking place predominantly in the liver, but various other organs like spleen, testis, sperm, placenta, etc. They are also capable of metabolizing fructose, though to a very small extent. But when we are talking about the galactose metabolism, the exclusive organ which is metabolizing galactose is the liver. And the pathway is pretty simple. You see, only few steps are there. And ultimately, you will see that galactose is utilized in the glycolysis. So let's see how this is going to be possible. For this, you must know the galactose is getting converted to galactose 1-phosphate, which is next converted to glucose 1-phosphate. This glucose 1-phosphate, with the help of one acute enzyme, is converted to glucose 6-phosphate, which is then utilized predominantly in the glycolysis. But if need arises and cell desire this galactose 6-phosphate for glycogen making, it can even go for glycogenesis. This kind of conversion of galactose to galactose 1-phosphate, galactose 1-phosphate to glucose 1-phosphate is all very important step which you must know. The first step is catalyzed by galactokinase enzyme, which uses ATP, and ATP phosphate is attached here. The next enzyme is going to transfer glucose from UDP glucose. So this glucose from UDP glucose is seen to be placed here, and this galactose, which was the intermediate of this pathway, is like taken away, is converted to UDP galactose. So I repeat again what is happening at this important step. The galactose 1-phosphate visibly is seen to convert itself into glucose 1-phosphate, but actually what is happening, the UDP glucose is coming as a donor of glucose, which is dropping the glucose in the mainstream pathway. You can see the color coding here. And the galactose is being kidnapped from the mainstream pathway, which is going away in the form of UDP galactose. This process, important process, is being catalyzed by one enzyme which is very, very important enzyme, and you must always remember this enzyme name, and this enzyme name is galactose 1-phosphate uridyl transferase enzyme. Galactose 1-phosphate uridyl transferase enzyme. Galactose 1-phosphate. Never forget this name. This name is very, very important name, otherwise called Kali-Put enzyme. I'll tell you the reason later why this enzyme name is so important for you. So galactose 1-phosphate uridyl transferase enzyme is transferring the glucose from UDP glucose, which is dropped in the mainstream pathway like this. Now coming to the next enzyme, which is shifting the 1st phosphate to the 6th position, and that enzyme is known as phosphoglucomutase. This enzyme is known as phosphoglucomutase. PGM, you can remember it as PGM, phosphoglucomutase enzyme. So if you see overall, the pathway of galactose metabolism is not very extensive pathway. You have only few steps, which is converting galactose to galactose 1-phosphate. Galactose 1-phosphate is converted to glucose 1-phosphate, glucose 6-phosphate, and ultimately it is getting utilized. This outgoing UDP galactose, which you can see here, is epimerized. At the outset, it is getting epimerized. which, continues the supply of UDP glucose this fashion. And this epimerization is a reversible equation catalyzed by 4-epimerase enzyme. 4-epimerase enzyme. So, if you see, there are 3 important enzymes which are dedicated enzyme for galactose metabolism. Number 1, galactokinase. Number 2, galactose 1-phosphate uridyl transferase enzyme. And number 3, the 4-epimerase enzyme. If you talk about phosphoglucomutase enzyme, this enzyme, though it is required for galactose metabolism, it is not a dedicated enzyme for galactose metabolism. ये enzyme आपको और भी जगह चाहिए होता है, ग्लाइकोजन के मेटाबॉलिज्म में चाहिए होता है, phosphoglucomutase, जो मैं आपको आगे पढ़ाऊंगी. Glycogen metabolism, synthesis of glycogen, breakdown of glycogen, both these pathways require phosphoglucomutase. Why we talk about this pathway so fondly is the reason that this pathway, if shows the deficiency of some or other enzyme, the baby suffers. Baby develops a disease known as galactosemia. And that's not very uncommon inborn error of metabolism. When we talk about galactosemia, we have problems like, so the galactokinase deficiency results in benign galactosemia. You remember this, benign galactosemia, which is not that benign because baby is having the cataract, the opacity of the lens, bilateral cataract, baby is blind, baby is unable to see. I'll tell you the reason why there is a cataract in galactosemia. So if anybody asks you what is the enzyme deficiency in benign galactosemia, just name the first enzyme, that is galactokinase, and that deficiency results in cataract formation. When we talk about the deficiency of second enzyme, that is Galliput enzyme, we have another type of galactosemia which is called classical galactosemia. Classical galactosemia. Classical galactosemia is having many problems. The baby with the classical galactosemia is having hepatomegaly. Liver will be enlarged. In benign galactosemia, there is no liver enlargement. But in classical galactosemia, what you see in the pathway, what is being accumulated is galactose 1-phosphate in the hepatocyte because the further steps are blocked. Galliput enzyme deficiency results in accumulation of galactose 1-phosphate in hepatocyte. उसकी वजह से liver cell बड़ी हो जाती हैं, hepatomegaly. So hepatomegaly is due to deposition of galactose 1-phosphate. In addition to this particular problem, the baby, of course, is having cataract. If anything goes wrong in the galactose metabolism, the cataract is inevitable feature. Cataract तो होना ही होना है. मैंने जैसा बताया, I will tell you the reason of cataract formation, cataract as a complication in galactosemia. Just give me 5 minutes time. I will be telling you how there is a cataract formation in galactosemia. Both benign galactosemia and classical galactosemia, you will have bilateral cataract. The mechanism in both the conditions for cataract formation is same. The third characteristic, which is seen in classical galactosemic baby, is the hypoglycemic attack. Baby very frequently gets into hypoglycemic coma, and that results in mental retardation. In due course, the baby will be seen to have low IQ. So these facts you must remember, and if the patient baby with galactosemia is coming to your clinic, ask the mother not to give galactose or lactose in the diet. So the dietary advice given to mother of the baby who is having galactosemia is lactose and galactose free diet. Absolute absence of lactose and galactose from the diet is advised to the mother because galactose is a non-essential thing. Even if you do not provide the galactose in the diet, the baby will survive, baby will be healthy. And if you start giving the lactose or galactose to the baby who is having galactosemia, what will happen? These intermediates will be produced more and more in quantity, and the severity of the disease will be very high. So, lifelong restriction. Lifelong, this kind of diet is to be given. Formula diet to the baby is given. You never have to resume to normal diet in galactosemic baby. Now, coming to the reason why there is cataract formation in galactosemic baby. You'll be surprised to know the reason for this cataract formation in galactosemic baby is very, very simple. This galactose, which is circulating high in quantity in blood, enters the lens cell where it is converted to galactitol, which is a hygroscopic alcohol. Galactose in the lens cell is converted to galactitol, which is hygroscopic alcohol. This particular enzyme is known as aldose reductase. You must remember this enzyme. This enzyme is the culprit of cataract formation, not only in galactosemia. I will shortly tell you, even in the diabetic patient, the enzyme aldose reductase is responsible for, cataract formation. In diabetic patient, when glucose is high in the blood, that enters the lens cell, where the same enzyme aldose reductase is going to reduce this glucose to sorbitol, which is again a hygroscopic alcohol. Hygroscopic alcohol. Hygroscopic alcohol समझते हो? The alcohol which is having the tendency to attract water. तो क्या होगा? लेंस में ये गैलेक्टिटॉल हो या डायबिटीज में सॉर्बिटॉल हो, दे विल स्टार्ट अट्रैक्टिंग लॉट ऑफ पानी आ जाएगा, लेंस में भर जाएगा और लेंस के सेल स्वेल होंगे, बस्ट हो जाएंगे, कैटरैक्ट बनना शुरू हो जाएगा. तो आपसे ये पूछेंगे, भाई कैटरैक्ट होता क्यों है? व्हाट इज द एंजाइम विच कैन बी टारगेटेड इफ यू वांट टू रिड्यूस दिस कॉम्प्लिकेशन ऑफ कैटरैक्ट? तो आपका आंसर होगा एल्डोज रिडक्टेज की मरम्मत कर दो, इसको काम ना करने दो, कोई दवाई दे दो, इसकी एक्टिविटी ब्लॉक कर दो, तो कैटरैक्ट बनने की नौबत नहीं आएगी, गैलेक्टोसीमिया में भी और डायबिटीज पेशेंट में भी. और ये सारे आपके सवाल होते ही हैं कि भाई गैलेक्टोस मेटाबॉलिज्म में जो कैटरैक्ट होता है वो किसकी वजह से होता है ना, गैलेक्टोसीमिया में, और ग्लूकोज के डिरेंज्ड मेटाबॉलिज्म में डायबिटीज में जो कैटरैक्ट होता है वो किसकी वजह से होता है. तो आप गैलेक्टिटॉल और सॉर्बिटॉल का नाम ले लीजिएगा. और एक बात आप समझ लेना, द नेचर ऑफ कैटरैक्ट. नेचर ऑफ कैटरैक्ट इन galactitol cataract, that is galactosemia cataract, is going to be oil drop cataract, which will look like as if you have put a drop of oil in the lens. And diabetes cataract, which is because of sorbitol, is known as snowflake cataract. Snowflake cataract, like this. Flakes of snow will be seen in the lens of the eye of a diabetic patient. Snowflake. I can show you a picture which is showing you the oil drop cataract in galactosemic baby. Can you appreciate this? Can you see a drop of oil here, type of appearance? This is a classical presentation of galactosemic cataract, the oil drop cataract. Right? And you can see this picture where mental retardation, organomegaly is all shown in the galactosemic baby. You can see in this picture all the food items which are having high content of lactose and galactose is shown. Can you identify these food items? This, of course, is milk. This is probably cheese, butter. This is also cheese cubes. I don't identify all these things. If you can identify, you can tell me this is curd. So this is all these dairy products are having rich amount of galactose and lactose, which should be avoided, absolutely avoided in a baby with galactosemia. All right. So this is all about the galactose metabolism. There is no big deal in galactose metabolism. I summarize what I have taught you. I have taught you that galactose metabolism is a simple metabolism where only few enzymes are required. Ultimately, galactose is going to enter in the glycolytic pathway where it is utilized for ATP production. And only few steps are needed to convert galactose to glycolytic intermediate. And those few steps I have shown you here, catalyzed by galactokinase, Caliput enzyme, phosphoglucomutase. At outset, one enzyme is there that's called 4-epimerase, right? And ultimately, this glucose 6-phosphate, which is produced, enters either in glycolysis or enters in glycogenesis. Deficiency of galactokinase results in benign galactosemia, and deficiency of galactose 1-phosphate uridyl transferase results in classical galactosemia. Benign galactosemia is characterized by cataract alone, and classical galactosemia is characterized by hepatomegaly, cataract, and mental retardation. So this is about the galactose metabolism. Now, if any doubt, you can ask me. I have told you all these are going to be your MCQ, going to be your short answer question. Right. Yes. Oil drop cataract is the characteristic feature of galactosemic cataract. And diabetes cataract will be snowflake appearance. You always remember it. All right. Now, next to this pathway of galactose metabolism, it is the time that I discuss you the HMP pathway. HMP pathway. It's a very, very special pathway. Which otherwise is called pentose phosphate pathway. Pentose phosphate pathway. HMP pathway, otherwise called pentose phosphate pathway or PP pathway. In this pathway, glucose is oxidized, but there is no ATP production. Unlike your glycolysis, where the glucose oxidation takes place for the main purpose of ATP production, when we talk about HMP pathway, here also glucose is oxidized, but there is no ATP generation in this pathway. So you may ask me, then what is the purpose of this oxidative pathway? The answer is NADPH production and ribose 5-phosphate production. NADPH production and ribose 5-phosphate production. These two important compounds are generated in this pathway. NADPH can get generated into various other minor pathways as well, but ribose 5-phosphate exclusively is generated in HMP pathway alone. Now you may ask me, why for these compounds are being produced? What is their use? They're very, very useful. Let me tell you, don't underestimate them. NADPH is not NADH. So, of course, we understand, and it is not going to go to electron transport chain, and hence no ATP is going to get generated from this NADPH. But then also, this NADPH play very, very important role in reductive biosynthesis, where reduction of intermediates are required. Reductive biosynthesis, which is fatty acid synthesis, steroid hormone synthesis. All these pathways, they require NADPH hydrogen. So NADPH is needed for these biosynthetic pathways where fatty acid is getting synthesized, where steroid hormones are getting synthesized. Bile acid synthesis also require NADPH. Bile acid synthesis also require NADPH. So reductive biosynthesis needs NADPH. And at the same time, the NADPH is also needed to handle oxidative stress in the cell. Oxidative stress in the cell. The H2O2 is a major oxidative stress. If this H2O2 is not handled carefully, it will start converting to hydroxyl ion, which is going to be a very toxic free radical. So to handle this H2O2, NADPH is required. So we understand this HMP shunt pathway, which is generating NADPH, is playing very, very important role in reductive biosynthesis in handling the oxidative stress. I can further emphasize, मैं और बता सकती हूँ कि भाई ये H2O2 को NADPH की क्या जरूरत पड़ेगी. In body we have a defense mechanism जिसमें ये H2O2 वाटर में कन्वर्ट हो जाएगा. इसके लिए चाहिए 2 हाइड्रोजन जो 2 मॉलिक्यूल ऑफ ग्लूटाथियोन से आएगा, जो कि होगा रिड्यूस्ड ग्लूटाथियोन, और ये अपना हाइड्रोजन दे देगा तो ऑक्सीडाइज्ड ग्लूटाथियोन बन जाएगा. ऑक्सीडाइज्ड ग्लूटाथियोन बन जाएगा और इस ऑक्सीडाइज्ड ग्लूटाथियोन को वापस हमें NADPH के हाइड्रोजन से रिड्यूस करना पड़ेगा. And this reaction will need the enzyme glutathione reductase. Which is FAD requiring enzyme. This enzyme, which is donating hydrogen from reduced glutathione to H2O2, is called glutathione peroxidase. Glutathione peroxidase. So this is how you need to have supply of NADPH from HMP shunt pathway to handle the H2O2 to detoxify it to water. If there is a problem in HMP shunt pathway and it is not able to supply NADPH, तो दिक्कत हो जाएगी. H2O2 बढ़ जाएगा, फ्री रेडिकल जनरेट करेगा, सेल को डैमेज कर देगा, हिमोलिसिस हो जाएगी. So we understand. At this point, we understand that though there is no ATP production, ATP नहीं बनता HMP में, फिर भी HMP बहुत जरूरी है for production of NADPH, for production of ribose 5-phosphate. तो NADPH का क्या काम है? वो ATP तो नहीं बना सकता, फिर काम क्या है? रिडक्टिव बायोसिंथेसिस काम है, हैंडलिंग ऑक्सीडेटिव स्ट्रेस काम है, और कितने काम करेगा? इतना तो करता है. राइबोस 5-फॉस्फेट क्या करेगा? बच्चा जानता है राइबोस 5-फॉस्फेट ये एक इंपॉर्टेंट पेंटोज है विच इज नीडेड फॉर न्यूक्लियोटाइड बायोसिंथेसिस. ये आप स्कूल से पढ़ते आ रहे हो कि फॉर मेकिंग ऑफ न्यूक्लियोटाइड, वेदर इट इज प्यूरिन न्यूक्लियोटाइड और pyrimidine न्यूक्लियोटाइड, यू नीड टू हैव राइबोस 5-फॉस्फेट एज प्रिकर्सर. और बॉडी में कहां से आएगा? हमारे खाने पीने से थोड़ी राइबोस 5-फॉस्फेट आ रहा है. वो आ रहा है तो HMP shunt पाथवे के इंटरमीडिएट में आ रहा है. ठीक है, तो इस तरीके से आप सिग्निफिकेंस ऑफ HMP shunt पाथवे के बारे में बात करते हो. सिग्निफिकेंस. में कोई डाउट है तो आप पूछो, अदरवाइज हम एक्चुअल पाथवे की बात करने जा रहे हैं जो साइटोसॉल में होता है. दिस इज अ साइटोसॉलिक पाथवे हैविंग मल्टीपल स्टेप्स. और मैं आपको सच बता रही हूं, अगर मैंने ये पाथवे आपको दिखा दिया तो आप डर जाओ, आप भी पानी पी. दिखाती हूँ ये पाथवे, देखो. देखना चाहते हो ये पाथवे कितना सुंदर दिखता है? आई शो यू दैट पाथवे. Yeah. Can you see this pathway? It has got so many reactions. These steps. Can you see? Oh my God. These are the various reactions of HMP shunt pathway. So if you see this in at night, you will be scared. It has multiple steps. And the most interesting point which you see here, we are not talking about single glucose 6 phosphate. We are talking about 3 glucose 6 phosphate which is going to enter in the HMP shunt pathway at once. 3 glucose 6 phosphate एक साथ जाते हैं. अभी तक आपने देखा था गैलेक्टोज मेटाबॉलिज्म में एक गैलेक्टोज की बात हो रही थी, फ्रक्टोज मेटाबॉलिज्म में एक फ्रक्टोज की बात हो रही थी, ग्लाइकोलिसिस में एक ग्लूकोज की बात हो रही थी. बट एचएमपी शंट पाथवे में वी आर नॉट टॉकिंग अबाउट द डेस्टिनी ऑफ सिंगल ग्लूकोज और ग्लूकोज 6 फॉस्फेट. वी आर टॉकिंग अबाउट 3 ग्लूकोज 6 फॉस्फेट टुगेदर. क्योंकि ऐसे ही होता है ये पाथवे. शुरू में तो ये इंडिविजुअली मेटाबोलाइज होंगे, अलग अलग मेटाबोलाइज होंगे, इस तरीके से अलग अलग मेटाबोलाइज होंगे, लेकिन बाद में इंटरमीडिएट्स आपस में मिलने लग जाएंगे, शफल करने लग जाएंगे. इन द सेकेंड हाफ ऑफ द पाथवे ये इससे मिल गया तो ये बना, ये टूटा तो ये बना, वो उससे गया मिला तो ये बना. सो कहने का मतलब है दिस पाथवे ऑफ एचएमपी शंट पाथवे इज अ वेरी वेरी कॉम्प्लेक्स पाथवे. बट देन ऑल्सो यू नीड टू रिमेंबर how this pathway actually occurs and what all types of question can be targeted to you in this pathway. What all enzymes are required? What is the enzyme deficiency associated disease in this pathway? A lot of things. And if I say ribose 5-phosphate is intermediate, how exactly that ribose 5-phosphate is getting produced? In addition to ribose 5-phosphate, what other 5 carbon compounds are produced as intermediate? You can see xylulose, ribulose. So there are a lot of questions in this pathway. For your MCQs, for your short answer question, for your long answer question. So you simply cannot leave this pathway and go coolly to the exam. So you have to prepare this pathway, these reactions, how to understand these reactions. So I'm going to simplify this pathway for you, and please understand, you will easily understand how this pathway is going to take place. Now, I'm going to write 3 glucose 6 phosphate here, which are independently metabolized first. Okay? This is converted to 6 phosphogluconate. This is again converted to 6 phosphogluconate. 6 phosphogluconate. Glucose 6 phosphate converted to 6 phosphogluconate, which is next converted to ribulose 5 phosphate. Ribulose 5 phosphate. Of course, this is 6 carbon, this is 6 carbon, this is 5 carbon. So there is some decarboxylation here. This is also converted to ribulose 5 phosphate. As I told you, initially, all the 3 glucose 6 phosphate will be meeting the same fate. At this step, there is formation of NADPH. Here also NADPH formation is seen. 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 और यहाँ भी NADPH बन जाए. So these are the reactions where NADPH is being generated. This enzyme is called G6PD, G6PD, G6PD. G6PD means glucose 6-phosphate dehydrogenase enzyme. This enzyme is 6-phosphogluconate dehydrogenase, 6-phosphogluconate dehydrogenase, 6-phosphogluconate dehydrogenase. Till this, we have the steps which are independent, and this is called oxidative phase of HMP shunt pathway. Oxidative phase of HMP shunt pathway. Beyond this, we have conversion of this ribulose 5-phosphate into xylulose 5-phosphate. xylulose 5-phosphate, and this ribulose 5-phosphate is converted to ribose 5-phosphate. They all are isomerized. Then these two 5-carbon combine to form your 10-carbon intermediate, which breaks into 7-carbon and 3-carbon intermediate. Now from here you start seeing the complexity of reaction. Till now the things were cool. I mean, few reactions converted glucose 6-phosphate to ribulose 5-phosphate, which then is isomerized to, other 5-carbon compounds. Now here onward, if you see this 5-carbon combine to make you 10-carbon, which splits into 7 and 3-carbon, which again combine to make you 10-carbon, which again is split to make you this time the 6-carbon and 4-carbon. This 6-carbon is isomerized to another 6-carbon compound, and this 4-carbon combines with leftover 5-carbon compound. You see the complexity. And that is what is shown in that picture which I showed you just some time back. So this 4 and this 5-carbon compound together will join and will make you 9-carbon compound, which will break into 6-carbon and 3-carbon compound. This 6-carbon is isomerized to another 6-carbon compound. And that finishes the HMP Shin pathway. Do you understand? These reactions are all reversible, where all these compounds are combining, breaking, making new compounds every time. This is called non-oxidative phase of HMP Shin pathway. This ribulose 5-phosphate can be used as a marker. Before this ribulose 5-phosphate, all the steps are oxidative phase steps. But beyond ribulose 5-phosphate, where the intermediates are condensing, dissociating, making many beautiful intermediates, is called non-oxidative phase of the HMP Shin pathway. इसको क्या बोलेंगे हम? Non-oxidative. ये कोई NADPH यहाँ नहीं बन रहा. Non-oxidative phase of HMP Shin pathway. So ये आप समझ लेना कि NADPH का जनरेशन ऑक्सीडेटिव फेज में होगा और राइबोस 5-फॉस्फेट का फॉर्मेशन नॉन ऑक्सीडेटिव फेज में होगा. और यहीं से निकल लेगा राइबोस 5-फॉस्फेट इफ इट इज प्लानिंग टू मेक यू न्यूक्लियोटाइड. लिवर में होता है प्रीडोमिनेंटली ये पाथवे. राइबोस 5-फॉस्फेट निकल लेगा पतली गली से, कहेगा भैया चला मैं तो न्यूक्लियोटाइड बनाने, तो और ग्लूकोज कन्वर्ट हो जाएंगे और राइबोस 5-फॉस्फेट सप्लाई कर देंगे. So this is how this pathway takes place with lots of complexity. You have ribose 5-phosphate production as an intermediate. You have NADPH production as a byproduct of the reaction. Now this is the time to focus on this enzyme. This is G6PD enzyme, a very, very known enzyme. If you see and certain MCQs, every time they ask you about this G6PD deficiency, G6PD enzyme deficiency results in what? G6PD enzyme deficiency. This G6PD enzyme deficiency results in hemolytic anemia. Why there is hemolytic anemia in G6PD deficiency? The answer is very simple. In G6PD deficiency, there is lack of NADH, lack of NADPH. So the oxidative stress is not handled, and RBC kind of cells, which are very fragile, breaks down easily and will result in hemolytic anemia. The precipitating factors which precipitates the hemolytic anemia in a patient who is having borderline deficiency of G6PD, those precipitating factors are primaquine drug, which is antimalarial. This produces a lot of oxidative stress in the cell. So this primaquine, if the patient gets malaria and doctor decide to give The Primaquine, after 2 days, patient comes and say, डॉक्टर साहब कैसी दवाई दे दी थी? मेरा मलेरिया तो ठीक हो गया, लेकिन अब मुझे जॉन्डिस हो गया, hemolytic jaundice हो गया. So Primaquine is a notorious drug which tends to precipitate G6PD deficiency. तो इसको देने से पहले हमेशा पेशेंट से हिस्ट्री लो कि कभी आपको G6PD deficiency तो डायग्नोज नहीं हुआ. Primaquine, even ciprofloxacin is a drug which induces a lot of oxidative stress in the cell. Tetracycline. तो ये सारे गड़बड़ करेंगे. Ciproflox, tetracycline, Dapsone, ये सब दवाई देने से पहले आप पूछोगे पेशेंट से कि भाई तुम ठीक ठाक तो हो, G6PD डिफिशियंसी तो नहीं है, बॉर्डरलाइन तो नहीं है G6PD. If it is, then don't give these drugs because patient will get hemolytic anemia and he will be very morbid. Similarly, consumption of fava beans consumption. Fava beans, if you go to vegetable market, you will see this fava beans, beautiful fava beans, which are mainly used in Chinese food items like fried rice and all. That also induces oxidative stress in the cell, and the patient who is having borderline G6PD will tend to develop hemolytic anemia after having a treat in Chinese restaurant. So patient coming with hemolytic anemia always ask, भैया क्या खाया था कल? If patient says कि भैया Chinese restaurant गए थे, fava beans का वाला fried rice खाया था, उसी के बाद से दिक्कत शुरू हुई है. तो इसका मतलब that patient is having borderline G6PD deficiency. ठीक है? fava beans देखना चाहते हो? दिखाती हूँ. Chinese food items में use होता है. And I will see if I have that picture. Yes. है ना? ये होता है. खाया है कभी? Okay. And this is, you can see the icterus conjunctiva, which is with which patient is coming and बोलता है देखो मेरी आंखों को क्या हो गया. So this is all hemolytic anemia, hemolytic jaundice, which the patient is going to show. So that is all about the HMP shunt pathway. Can you see the dotted line here in this picture, which is telling you the demarcation between the oxidative phase and non-oxidative phase? Multiple reactions are there, but I have told you the core reactions which you need to remember. And please remember these reactions which are needed to convert the various intermediates. And I will just name 2 enzymes. Number 1, the transaldolase. And number 2, trans ketolase. These 2 enzymes, transaldolase and trans ketolase, are the enzymes which are catalyzing these interconversions of various intermediates. So that is all about HMP shunt pathway. And if you have any doubt in your mind, you can ask me. Again, I say this pathway does not generate ATP. None of the reaction you have seen which generates ATP. This pathway is meant for production of NADPH, meant for production of, you see, ribose 5-phosphate. And these compounds, they have their own significance in our system. ठीक है, बताओ भी कोई दिक्कत हो पूछ लो. MCQs में यही सब आएंगे. G6PD deficiency, hemolysis, giving Primaquine, and hemolysis is precipitated. What may be the problem in this baby? And nothing much can be done. These are the enzyme deficiencies, and enzyme replacement is not very successful. It's not a permanent cure. Now, once you have learned this, I would like to discuss one more pathway of carbohydrate metabolism, which is the uronic acid pathway. This is again a very important pathway because it has got a lot of MCQ for you in this pathway. So when we talk about this pathway, in this also glucose is utilized. And if you talk about the organ, it is the liver where this pathway is taking place and glucose is converted to glucuronic acid. This is glucose, and after few steps, it is converted to UDP glucuronate. So the reactions are very well shown here. The glucose is converted to glucose 6-phosphate by glucokinase enzyme, which is next converted to glucose 1-phosphate by phosphoglucomutase enzyme. And this glucose 1-phosphate is converted to UDP glucose by UDP glucose pyrophosphorylase enzyme, which is next converted to UDP glucuronate by glucose dehydrogenase enzyme. Then this UDP glucuronate is converted to D-glucuronate, which is next converted to L-gluconate. L-gluconate, decarboxylated, 5-carbon compound, L-xylulose is formed, which is converted to xylitol and D-xylulose. L-xylulose, xylitol and D-xylulose. This area becomes very, very important in this pathway because this has got hidden MCQs in this. And this D-xylulose is either converted to oxalate and excreted out in the urine, or it is converted to going to enter in the pentose phosphate pathway and getting utilized there. You have seen just now that in PP pathway or HMP shunt pathway, xylulose is one of the intermediate. So how are you going to remember this flow of intermediates? You please remember glucose, glucose 6-phosphate, glucose 1-phosphate, UDP glucose, UDP glucuronate, and then D-glucuronate, L-gluconate, and that is decarboxylated to produce L-xylulose, xylitol, D-xylulose. Now what becomes very, very important in this pathway is this area which I have just bracketed just now, L-xylulose, xylitol, D-xylulose. This is xylitol dehydrogenase enzyme, and this is D-xylulose reductase enzyme. Xylitol dehydrogenase enzyme and D-xylulose reductase enzyme. Never forget these names. Deficiency of this xylitol dehydrogenase results in excretion of L-xylulose in the urine. This is called essential pentosuria. They'll directly ask you, they're very cruel, your examiners are very cruel. They'll ask you, what is essential pentosuria? Which pathway is involved? You say uronic acid pathway is involved. What is the enzyme deficiency? Essential pentosuria. What is the enzyme deficiency? Remember this name, it's a xylitol dehydrogenase enzyme deficiency. What pentose is excreted in the urine? L-xylulose or D-xylulose? Remember, it is L-xylulose. Why it is called essential pentosuria? Because it is a benign pentosuria. So all these questions are there for you in MCQs waiting for your answer. So essential pentosuria, the key points, the uronic acid pathway is affected, xylitol dehydrogenase is deficient, L-xylulose is coming out in the urine. It's a completely benign condition. The patient will have no problem, no sign and symptoms at all. One more interesting point in this pathway is there, and that point is this pathway is capable of making you vitamin C, but not in human. Mind it, in human vitamin C is not synthesized in the body. क्या हम vitamin C बनाते हैं? नहीं ना, हम तो lemon खाते हैं, हम तो guava खाते हैं. Then that gives us vitamin C. We don't synthesize. We consume via lemon, lime juice, etc., etc. And that is why lemon is so expensive in the market. क्योंकि हमें लेना पड़ता है ना, नहीं लिया तो स्कर्वी हो जाएगा, ब्लीडिंग गम्स हो जाएंगे. बॉडी में नहीं बनता है स्कॉर्बिक एसिड ह्यूमन बॉडी में, बट लोअर प्राइमेट्स में बनता है. यूरोनिक एसिड पाथवे लोअर प्राइमेट्स में एस्कॉर्बिक एसिड बनाते हैं. और अगर आप ये देखो, एल-ग्लूटामेट चल देता है एस्कॉर्बिक एसिड बनाने. और आपको दुनिया की बातें याद नहीं रखनी है. ये पाथवे विटामिन सी क्यों नहीं बनाता ह्यूमन में, एस्कॉर्बिक एसिड क्यों नहीं बनाता, तो आपको एक लाइन में ये याद रखना है जो मैं यहां लिख रही हूं, ड्यू टू लैक ऑफ एंजाइम एल ग्लूनो लैक्टोन ऑक्सीडेज, human is not capable of synthesizing vitamin C. 1000 times. This enzyme name you remember, L-gulonolactone oxidase, is deficient in human, and that is the reason vitamin C is not synthesized in the uronic acid pathway. So this pathway, uronic acid pathway, is important for short answer question, but at the same time you need to remember that for MCQs this pathway is very, very important. You have selective MCQs like the purpose of uronic acid pathway. You say formation of UDP glucuronic acid, which is important as a conjugating agent. Conjugation होता है ना xenobiotics का, bile acids का, तो उसमें ये UDP glucuronate काम आता है. Conjugating, it is a conjugating agent. और ये UDP glucuronate म्यूकोपॉलीसैकेराइड भी बनाने का काम करता है. म्यूकोपॉलीसैकेराइड बनाने का भी काम करता है. म्यूकोपॉलीसैकेराइड बनाने का भी काम करता है. ग्लूकोनिक एसिड प्रोवाइड करता है. और इस पाथवे में कुछ खास बात है नहीं. ह्यूमन में देखिए एस्कॉर्बिक एसिड तो बन रहा है. इस पाथवे में पर्पस अगर पूछे ह्यूमन में क्या है तो वो यही है, यूडीपी ग्लूकुरोनिक एसिड बनाना है, which will be needed for conjugation reactions, which will be needed for, the mucopolysaccharide synthesis. Then other MCQs are essential pentosuria. What pentose is excreted? It is L-cellulose. What enzyme is deficient? It is xylitol dehydrogenase, right? And why uronic acid pathway is not able to produce ascorbic acid in human cell? The lack of enzyme L-gulonolactone ऑक्सीडेज एंजाइम डिफिशियंसी. ठीक है, तो ये सब कहानी है आपकी यूरोनिक एसिड पाथवे में. और सिर्फ लिवर में ये पाथवे होता है, थोड़ा सा ग्लूकोज उस पाथवे में यूटिलाइज हो जाता है. एटीपी जनरेशन यहाँ भी नहीं, ये भी साइटोसोलिक पाथवे, इधर भी एटीपी जनरेशन की बात नहीं होती. इफ यू आर टॉकिंग अबाउट ग्लूकोज ऑक्सीडेशन एंड प्रोडक्शन ऑफ एटीपी, इट इज ओनली ग्लाइकोलिसिस जहां पर एटीपी जनरेशन होता है. यूरोनिक एसिड में नहीं होता, एचएमपी में भी नहीं होता. ठीक है, तो बच्चे कोई सवाल पूछ लो. मिस्टर आलम, आपको समझ में आ रही है? तो आज हमने 3 इंपॉर्टेंट पाथवे डिस्कस कर लिए, जो मैंने सोचा भी नहीं था. मैंने तो सोचा तो 2 पाथवे डिस्कस हो पाएगा. आप तो इतने प्यारे हो कि 3 हो गए डिस्कस. एक हमने गैलेक्टोज मेटाबॉलिज्म देख लिया, जिसमें हमने देखा कि कैसे कैटरैक्ट बन जाता है, ऑयल ड्रॉप कैटरैक्ट बन जाता है, एल्डोज रिडक्टेज एंजाइम है, क्लासिकल गैलेक्टोसीमिया, बिनाइन गैलेक्टोसीमिया, ये सब पढ़ा. और मदर से बोल दिया भैया जिंदगी भर इसको लैक्टोज गैलेक्टोज मत देना, इट इज अ नॉन एसेंशियल थिंग. उसके बाद हमने मुद्दा शुरू किया भैया एचएमपी शंट पाथवे कैसे पढ़ा जाए, क्यों पढ़ा जाए. क्यों पढ़ा जाएगा? आंसर है भैया एनएडीपीएच बनाकर देगा, राइबोस 5 फॉस्फेट देगा. क्या काम है एनएडीपीएच का? एटीसी में तो जाता नहीं है, तो नहीं जाता है तो ना जाए. एटीपी तो नहीं बनाएगा, लेकिन काम बहुत सारे करेगा. तो एनएडीपीएच क्या काम करेगा? रिडक्टिव बायोसिंथेसिस करेगा. और क्या काम करेगा? ऑक्सीडेटिव स्ट्रेस को हैंडल करेगा. तो ऐसे आप बार बार इस चीज को रिवाइज करिए, जादू की तरह याद नहीं होगा. बायोकेमिस्ट्री है, बच्चों का खेल थोड़ी है. ठीक है, तो एनएडीपीएच ने क्या किया? रिडक्टिव बायोसिंथेसिस किया, H2O2 को पकड़ा, उसे पानी पानी कर दिया. तो वहां पर हमने देखा ग्लूटाथियोन परऑक्सीडेज, ग्लूटाथियोन रिडक्टेज एंजाइम, इन सब की बात हुई. वो भी एमसीक्यूज है आपके. फिर राइबोस 5 फॉस्फेट का जब मुद्दा आया तो हमने देखा कि भैया राइबोस 5 फॉस्फेट इज वन ऑफ दोस 5 कार्बन इंटरमीडिएट्स इन एचएमपी शंट पाथवे. यही सारी तो बातें हमने की हैं इतनी देर से. और ये राइबोस 5 फॉस्फेट पतली गली से निकल देगा भैया. चला मैं तो न्यूक्लियोटाइड बनाने, वेदर इट इज प्यूरिन न्यूक्लियोटाइड और इट इज pyrimidine न्यूक्लियोटाइड, ये चाहिए होगा तो कहीं और से नहीं आएगा. देयर इज नो अदर पाथवे which can provide you the ribose 5 phosphate. It is only HMP शंट पाथवे. एनएडीपीएच तो और भी कहीं से आ सकता है, मैलिक एंजाइम से आ सकता है ना, आइसोसिट्रेट डिहाइड्रोजनेज से आ सकता है. मेनली तो एचएमपी से ही आता है एनएडीपीएच भी, लेकिन राइबोस 5 फॉस्फेट तो कहीं और से आ ही नहीं सकता. बनना है इसी पाथवे में. तो आप देखिए ग्लूकोज सेक्रीफाइस हो रहा है फॉर द मेकिंग ऑफ राइबोस 5 फॉस्फेट. अल्टीमेटली कोई एटीपी वेटीपी हासिल नहीं हो रही इस एचएमपी शंट पाथवे में. ठीक है, तो ये सारी कहानी आप याद करिए, कहानी की तरह याद करिएगा, तभी आपके कॉन्सेप्ट क्लियर होंगे. जब भी आप इसको क्लिनिक्स में अप्लाई कर पाओगे, जब भी आप अपने एमसीक्यूज को ठीक तरीके से सॉल्व कर पाओगे. आप क्या मजाक समझ रहे हो? आपको क्या लग रहा है ये एचएमपी शंट पाथवे बैठ के सुबह 4 o'clock का अलार्म लगा के बैठ के रटोगे तो रट जाएगा? कभी जिंदगी में नहीं रटेगा, अनलेस अंटिल यू मेक द कॉन्सेप्ट आउट ऑफ इट. And I have told you how to make concept. You start the journey with 3 glucose, 6 phosphate, and you see initially the independent reaction. Then काम की बात सिर्फ इतनी है, मुद्दे की बात इतनी है कि इनिशियल उन रिएक्शंस में, डेडिकेटेड रिएक्शंस में NADPH बन रहा है. वहां मुद्दा आ जाता है G6PD एंजाइम का. मैंने कहा भैया वो ना डिफिशिएंट हो जाता है तो हिमोलिसिस हो जाती है. और वो रीजन भी मैं आपको बता दूं कि क्यों हो गई हिमोलिसिस. तो वो तो शायद अब तक आप समझ गए होंगे कि G6PD अगर डिफिशिएंट हो गया तो क्या कर सकते हैं. G6PD अगर डिफिशिएंट हो गया तो NADPH की सप्लाई बंद हो जाएगी और H2O2 शेयर हो जाएगा, फ्री रेडिकल्स बनाएगा, सेल को डैमेज करेगा. और उन पेशेंट्स में जिनमें बॉर्डरलाइन G6PD की डिफिशियंसी है, थोड़ा सा NADPH बन रहा है, थोड़ा सा नहीं बन रहा है, you have to be very cautious before prescribing any drug which stimulates the oxidative stress in the cell. Like, for example, the common antibiotics which are being used, the tetracycline, the doxorubicin, the dapsone, the ciprofloxacin, and the most notorious drug which should be avoided in G6PD deficiency is the primaquine, which is a anti-malarial drug. Primaquine should not be given, absolutely should not be given. That develops severe hemolysis. That becomes at times lethal as well. So you, as a clinician, you have to be really very careful before prescribing these highly oxidative drugs to the patient. Alright? तो ये पढ़ना है आपको HMP के बारे में. और यूरोनिक की कहानी तो कोई सबकी जुबान. फावा बीन्स की भी बात हुई थी कि भाई चाइनीज फूड खा लिया, खूब सारा फावा बीन्स डाल करके, अगले दिन वो सुबह पहुंच गया, डॉक्टर साहब मुझे तो हिमोलिसिस हो गई. देखो जरा कि G6PD की डिफिशियंसी तो नहीं है. ठीक है, तो ये सब कहानियां चलती हैं दुनिया में. आजकल तो पेशेंट डॉक्टर से ज्यादा होशियार हो रहे हैं, है ना. सारे AI वाले डॉक्टर हो गए. तो आप थोड़ा रियल इंटेलिजेंस वाले डॉक्टर हो जाओगे तो सही रहेगा, सर्वाइव कर जाओगे. अदरवाइज तो आर्टिफिशियल इंटेलिजेंस का जमाना है. आर्टिफिशियल तो चीजें आर्टिफिशियल ही मिलेंगी, असली चीज असली है. तो आप असली ज्ञान डेवलप करिए, इन चीजों को पढ़िए और अप्लाई करिए. अदरवाइज कल को पेशेंट ही क्लिनिक पे सिखा जाएगा आपको. यूरोनिक एसिड पाथवे की बात की तो मैंने कहा देखिए, शॉर्ट आंसर क्वेश्चन लिखने वाले बच्चे अगर आप अटेंड कर रहे हो तो ये शॉर्ट आंसर क्वेश्चन है. MCQs करने वाले बच्चे अगर आप इसे अटेंड कर रहे हो तो आप देखिए इसमें 5-6 गिने गिनाए MCQs हैं. वो सारी बातें हमने की. और 1-2 स्टेप्स बीच में उड़ भी जाए तो कोई फर्क नहीं पड़ता. लेकिन ये ब्रैकेट वाले स्टेप्स मत उड़ाना. L-xylulose, xylitol, D-xylulose. D-xylulose ultimately going to HMP shunt pathway and getting utilized there. अभी देखा था हमने HMP में xylulose is also one intermediate, है ना. फिर एसेंशियल पेंटोसोरिया, L-xylulose, xylitol dehydrogenase deficiency, benign condition, पेशेंट को तो पता भी नहीं चलता उसको एसेंशियल पेंटोसोरिया है, अच्छा खासा बड़ा हो जाता है, हेल्दी होता है, IQ भी अच्छा, नौकरी भी अच्छी लग गई, शादी वादी भी हो जाती है. एक्सीडेंटल डिटेक्शन ऑफ पेंटोस इन द यूरिन, क्योंकि L-xylulose इज अ रिड्यूसिंग शुगर. तो पेशेंट पहुंचा अपना रूटीन स्क्रीनिंग के लिए, पता चला यूरिन में बेनेडिक्ट टेस्ट पॉजिटिव आ गया. कहता है पेशेंट डायबिटीज तो मुझे है नहीं, अब बेनेडिक्ट टेस्ट यूरिन में कैसे पॉजिटिव आ रहा है, ग्लूकोज तो है नहीं, कुछ और है. तो फिर पता चला भैया ये तो L-xylulose. So it's an accidental detection of L-xylulose in the urine which hints you towards this diagnosis of essential pentosuria. वरना तो उस बंदे की शादी वादी भी होगी, सब राजी खुशी अच्छा चल रहा है, नौकरी भी अच्छी चल रही है, तो दिक्कत थोड़ी है उसकी जिंदगी. फिर हमने बात किया विटामिन C बनने की. ह्यूमन में नहीं बनता पहली बात, और क्यों नहीं बनता दूसरी बात ये है. क्यों नहीं बनता तो मैंने बोला एंजाइम का नाम रट के एग्जाम में जाना, वरना वापस आ जाना, मत घुसना एग्जाम हॉल में. एंजाइम का नाम क्या है, हर बार पूछते हैं, ये आएगा ही आएगा आपका इस बार. L-gluconolactone oxidase enzyme deficiency, इसकी वजह से there is no ascorbic acid formation in uronic acid pathway. लोअर प्राइमेट्स में एंजाइम होता है तो उनमें ये बन जाता है, ये विटामिन C बन जाता है. ठीक है, और बताइए जी. आलम जी सब समझ आ रहा है तो फूल पत्ती भेज दीजिए, थोड़ा सा हाय हेलो कर लीजिए, सो दैट आई अंडरस्टैंड कि आपको एक चीज समझ आ रही है. ठीक है, ये पढ़िए, और ये सारी चीजें इधर लिखी हुई हैं. यूरोनिक एसिड पाथवे अकर्स इन, चलिए फिल इन द ब्लैंक करते हैं. अकर्स इन द लिवर. ग्लूकोज इज ऑक्सीडाइज्ड फॉर प्रोडक्शन ऑफ UDP glucuronate, which is acting as a conjugating agent. Unlike lower primates, human is incapable of producing ascorbic acid due to absence of L-glucono lactone oxidase enzyme. Essential pentosouria is due to deficiency of xylitol dehydrogenase, which results in L-cellulose in the urine. ये सारी चीजें मैंने लिख लिख के आपको दे दी हैं, ठीक है। ओ वीरेंद्र प्रताप जी, आप भी हो, नमस्कार। आप कहाँ थे? तो ये है कहानी, बच्चा चल रहा। तो अभी आपने ये थर्ड सेशन हो रहा है और इसमें आपने देखा कि हमने बड़ी खास बातें की हैं। फर्स्ट सेशन में मैंने आपसे ग्लाइकोलिसिस की बात की, पीडीएच कॉम्प्लेक्स की बात की। मैंने आपसे बोला भाई टीसीए साइकिल में जाएगा। सेकंड सेशन में टीसीए साइकिल को उठाया, उसके बारे में बात की। फिर ग्लूकोनियोजेनेसिस भी ठोक दिया कि भैया उल्टा उल्टा जाएगा ग्लाइकोलिसिस, लेकिन पूरा उल्टा जा नहीं सकता, तो इरिवर्सिबल स्टेप्स को शंट करना पड़ेगा। तो वो सारी कहानी ग्लूकोनियोजेनेसिस की हमने बात की। उसके बाद धीरे से कहीं फ्रक्टोज मेटाबॉलिज्म भी पढ़ा दिया, और आज आई तो मैंने कहा गैलेक्टोज मेटाबॉलिज्म पढ़ लो। ये सब बहुत इंपॉर्टेंट, यू सिंपली कैन नॉट नेग्लेक्ट है, ठीक है। फिर गैलेक्टोज हुई तो वहां कैटरेक्ट की बात इतनी शुरू हो गई, और क्लासिकल गैलेक्टोसीमिया, बिनाइन गैलेक्टोसीमिया के डिफरेंसेस की बात हमने कर ली। उसके बाद मैंने कहा क्यों छोड़ा जाए, एचएमपी भी पढ़ लो, उसका सिग्निफिकेंस पढ़ लो, पीपी पाथवे जिसको कहते हो, पेंटोज फॉस्फेट पाथवे। फिर मैंने कहा इतना अच्छा पढ़ रहे हो तो यूरोनिक एसिड पाथवे भी पढ़ लो, उसका सिग्निफिकेंस कोई खास नहीं है भैया, एटीपी तो बनता नहीं है ना। तो खास सिर्फ इस मामले में है कि यूडीपी ग्लूकोरोनेट ह्यूमन में बनाकर देता है, और ह्यूमन में एस्कॉर्बिक एसिड क्यों नहीं बनता, बार बार बोलती हूँ, एंजाइम की डिफिशियंसी को आप याद रख लीजिए। तो इस तरीके से आप पढ़िएगा, मुट्ठी भर सामान है, पढ़ लीजिए, बहुत सारी चीजें कवर होती जाएंगी। और फिर से मैं आपसे एक बात बताना चाहूंगी कि दिस इज बायोकेमिस्ट्री, सो कीप रिवाइजिंग, कीप रिकॉलिंग, कीप डिस्कसिंग द पाथवेज, देयर क्लिनिकल सिग्निफिकेंस, द एंजाइम्स नेम, बार बार बोलिएगा तो वो चीजें याद हो जाएंगी। एंड आई टेल यू इट इज अ वेरी वेरी स्कोरिंग सब्जेक्ट, और अगर आप इसको अच्छे से पढ़ के जाओगे एग्जाम में तो नोबडी कैन स्टॉप यू फ्रॉम getting pass in FMG exam. Nobody can stop you in getting good rank and good seat in NEET and next exam. So wish you all the best. With this, I'll be stopping the class because otherwise बहुत ज़्यादा pathways पढ़ने से खिचड़ी बन जाती है, right? So आपको कोई doubt हो तो आप पूछ लीजिए, and another 2 minutes I'm online. Otherwise, good night. Thank you very much. In the next class, I will be meeting you with some other interesting pathways and we'll be talking their clinical connections. ठीक है? चलो जी, थैंक यू, गुड नाइट, शब्बा खैर।